two wonderful speakers tonight. So Dr. Damon Dierker is Director of Clinical Strategy and Optometric Services at Eye Surgeons of Indiana and is an adjunct faculty member at the Indiana University School of Optometry. He practices consultative optometry with special interest in ocular surface disease, glaucoma, retina, and perioperative care. He's developed a dedicated dry eye clinic within his practice and is a recognized educator in ocular surface disease as the creator of Dry Eye Bootcamp and co-founder of Eyes on Dry Eye. He's a past president of the Indiana Optometric Association. Welcome back to WooU.
Thank you.
And here are his financial disclosures. And Dr. Jacob Lang is a nationally recognized optometrist with expertise in ocular surface disease, corneal disease, dry eye, therapeutic contact lenses, and surgical co-management. He serves as president of the Intrepid Eye Society and is a fellow of the American Academy of Optometry with leadership experience in the Academy's anterior segment section. He is a chief educator and editorial board member for multiple optometric publications, has written and lectured extensively, and remains actively involved in clinical research, professional education, and consulting with eye care industries to advance evidence-based patient care and clinical innovation. And here are his financial disclosures. I wanted to get through all of that quickly because with two speakers, I know we have a lot to cover. So I'm going to turn it over to both of you, and I will be back at the end for Q&A.
Thank you, Dr. Stewart.
Yeah, so thanks for joining us all tonight. You know, it's an honor and a pleasure to be here with a good colleague and close friend. We rant about not only corneas, but also the Vikings on a frequent basis. So thanks for joining me, Damon. I'm also, yes, I'm wearing the same shirt that I was wearing.
I was going to mention that, Jake. You look a little younger, but the shirt looks the same. So well done. You're like Superman.
Yeah, right. Exactly. Yeah. So that was funny. But I hope you all are doing well out there. We're going to get into some conversations around, obviously, ocular surface disease, and specifically serum, and maybe why we should be reaching for serum sooner. Of course, that's the title of this. But why have we not? And kind of what have those barriers been? And are they real barriers, or are they something that we should maybe re-examine as things evolve and change with our understanding? Again, my financial disclosures as well as Dr. Dierker's have been mitigated. I think we talked about this, but what is serum? How can we use serum to help our patients is really the focus of this case-based lecture. The who, what, where, when, and why of autologous serum. When I think of serum in this setting too, you know, there's some discussion around like serum drops or platelet-rich drops. I think, you know, when I think of those as kind of from a high-level picture, we can include both of those things here tonight. We could get into the nuances of what the differences are, but I think for our conversation, our cases, would you agree, Damon, that could be just blood-derived serum drops?
Yeah, I mean, I think biologics, blood-derived products, and there's PRGF, there's other things out there, but, you know, getting back to, you know, why serum, why sooner, I think the big thing is access, right? So, I mean, for me, the last decade compared to the decade before, I have so many more people on a biologic because it's so much easier, the process to get it to them. And we were talking earlier offline, you know, I had 3 or 4 patients today that were new start serum, and it's something that it's on my mind. It's in a referral center clinic, but it's something I'm using more and more of because I see the results. It doesn't fix everything, but I think the access piece, especially for serum when we're looking at versus PRP or other things, the way that we can get serum to our patients, no matter where you practice in the United States, it really makes that something we're going to reach for.
Yeah, and I agree that, you know, kind of keep it simple is the old strategy in so many things, and keeping it simple with finding someone you can work with and getting patients access to this and making it happen. And there's opportunities to make it happen now more than ever, and to keep it simple. So let's talk about ocular surface disease. And you know, for the next 4 hours, we're going to focus on all things ocular surface disease. Now, obviously, a big topic too, right? So ocular surface disease could entail a lot of things. I think the biggest one we talk about is dry eye, right? Dry eye disease and the pathophysiology of dry eye disease. But as we go through this conversation tonight, I don't want the audience to limit themselves to just dry eye and thinking about dry eye. This could entail, corneal epithelial diseases and dystrophies and other things that affect the health of the ocular surface. So don't limit your thinking when you're listening to us jibber jabber about all this stuff. Like, think outside the box, be creative with your patients. A lot of what optometry takes care of is anterior segment disease, and there's so many things on the surface that are not just dry eye that serum can help with as well. When we talk about dry eye disease itself, the pathophysiology, that tear film instability, we know inflammation plays such a big role in so many ocular surface conditions, but dry eye disease as well. We know hyperosmolarity is one of the key findings, and that hyperosmolar state leads to epithelial damage, tissue damages, breakdowns, nerve damage. And we know there are also these neurosensory abnormalities where the feedback loops and the healing gets broken down. When I talk to my patients about their tears, a lot of what I'm telling them is your tears are the blood for your eye. And so if you don't have an adequate amount of tears on the surface of your eye is like gasping for air, right? It's starving for blood. And that resonates with a lot of patients. They're like, yeah, that's why my eyes burn, or, oh, that's what's going on. That's why I can't get ahead of this. I'm starving for blood. I'm suffocating here. And so aqueous deficient dry eye, Damon, when do you think like, oh, this is, if we can define dry eye, what makes you say, oh, this patient has aqueous deficient dry eye?
Yeah, so how do you define dry eye? How does I get in my chart? It's a symptomatic disease. If you look at the current definition, so they have to have some level of symptomatology, and that may not always be dry. That could be a lot of different things. And then they have some sort of loss of homeostasis, and we can see that with the elevated tear osmolarity, corneal conjunctival lid margin staining, and or reduced tear breakup time. So our job is to identify, is this patient symptomatic? How symptomatic? Do they have loss of homeostasis? And then for aqueous deficient, I did a Schirmer test today by a request. That was an unusual day. It's really looking at their history, looking at their osmolarity, and then just looking at their tear volume, their tear meniscus height. And if that's low, and this patient is symptomatic, I can easily make a diagnosis of aqueous deficient dry eye if we have one of those markers of loss of homeostasis. So I think it's common in advanced disease. It's common in people with systemic drivers autoimmune disease, but it's probably not in isolation. One of the most common things we see alone is usually going to be some sort of evaporative dry eye, MGD associated with most of our patients.
Yeah. I think you nailed it. The history is a big part, and then that tear meniscus height tells me like, hey, there's just not enough fluid on this eye. I think those are the two big ones that make me think. And then I was talking about this last night with someone too. Like, we see it more with more senior patients, right? We see it more with birthday candles and as well. So, autoimmune diseases, we put Sjögren's up here because it's kind of the hallmark of Sjögren's is dry eyes and dry mouth. We could talk about the testing for all those things, but in my clinic, I'm saying in the setting of Sjögren's, right? Dry eye in the setting of Sjögren's, which makes me think about things differently. I think about more aqueous deficiency, but it also, when I'm communicating this, when I'm sending letters back to referring providers, makes them think about it too. Rheumatologists, for example, internal medicine doctors, all that stuff. So I'm saying dry eye in the setting of lupus, rheumatoid arthritis, thyroid dysfunction, whether it be Graves or other, those sort of things. Putting that in the note, I think is very fun, or fun for me.
Patients want to hear that too. You hear all the time is, how did I get here? And it's usually not one thing. It's usually a list of things. But we want to understand when we're making the diagnosis and then thinking about how we're going to treat it, is what's driving this disease, right? And is it inflammation? Is it neurosensory abnormalities? Is it Demodex blepharitis? Is it MGD? And we want to really tackle the dominant drivers. And that's one of the nice things about Serum, is it hits a lot of those things. It doesn't kill Demodex, but it does a lot of other things that are going to help support your ocular surface. Yep.
Definitely nourishes the surface, right? And if we really think about the aqueous part of dry eye, it's really like blood serum which is where this has all come from. So if they don't have enough aqueous, maybe we should be thinking about using blood serum, the patient's own body, to heal itself. Can anything do better than our own bodies to help heal itself? And then, of course, evaporative dry eye. This is more of the MGD, meibomian gland, hyper-evaporative state. It can also be brought out by blink dynamics when we think about, just not re-nourishing that surface, pumping the tears, helping those meibums move, which has an aqueous effect as well. Blepharitis, the Demodex things you mentioned. When I think about some of those evaporative things too, frictional forces are a big thing, that if we don't have enough tears, especially, and I think it takes the whole tear film to avoid this, but we get those frictional forces, and we can have frictional diseases that we see, like SLK and other things that can cause more friction on the surface of the eye. And that's definitely something to recognize when we're talking about this.
You gotta look for it though, for sure. And that's where lissamine green is gonna help us. Gonna see lid wiper epitheliopathy, SLK. And we want to, when we're doing our evaluation, is not miss the things that are the hidden drivers, and friction is definitely one of those. Blink dynamics for sure. I had 2 patients today that their primary issue was incomplete blinking. Really, they had pretty good meibomian gland morphology. They didn't have a lot of inflammation. And these are cases where if you identify that they just need to, you literally prescribe blinking exercises, core blinking exercises, and this is very helpful. Sometimes you have to do obstruction removal too, but these are things that are common. And then again, it's very common to see both evaporative and aqueous deficient in patients as the disease is going to get, more advanced and longer they have it. They usually have things from both of those camps.
Yep. But if a patient has hyper evaporation, what's evaporating? It's the aqueous that's evaporating, and that leads to the problem. So if we can supplement, and Dues too talked about this a little bit if you dive into it, but if you can supplement the aqueous to be sufficient for the amount of evaporation that's occurring, you're still getting ahead of the disease process. And so serum plays a role with all of these because we can supplement what's evaporating. We can supplement what's inadequate in aqueous disease. So we have the opportunity to supplement what we're missing in all states. And I agree with you here that, there's a lot of crossover. There's a lot of mixed mechanism. When do you ever see just one in isolation? Whenever you see Sjögren's patients.
If it's really early and you're proactive about it, if you're waiting until they have corneal staining and a speed score of 25 and osmolarity 350, is like they got more than one thing going, because it just all this stuff causes collateral damage.
Yeah. So catch it early. I wish we could catch those early patients more. I don't see as many of those as I'd like. And we're going to talk a little bit about that being more progressive, which is kind of the topic of the evening. So let's talk about serum tears. So what are serum tears, and why are you doing this? So tell me, Damon, you ordered 4 new patients of serum tears. What did you order today? What did you get these patients?
So these patients had various presentations of epitheliopathy, neuropathic pain, neurotrophic disease, sometimes just recalcitrant dry eye symptoms, photophobia. I mean, those are things that are going to be things where I'm reaching earlier and earlier for serum. So I'll tell a patient, what is it that we're trying to treat, and why do we need to use something other than anti-inflammatory, anti-evaporative? We need to use a biologic. And very often the conversation goes to, we've treated your inflammatory problem, we've treated your glands. The symptoms that you're describing to me are due to a problem with the nerve, and we need something to nourish the nerves on the surface of the eye. Otherwise, the eye is not going to behave like it should. So that's the most common reason. And if you have a nerve issue, you really want to get these different growth factors that you're going to be able to concentrate into a biologic tear. You want to get those to the surface of the eye and do that in a way that's going to be easy for a patient to do. So what I will do is I'll order this. We will send them to a lab, and they'll do a blood draw, and then the serum gets processed and then shipped to the patient. And it used to be that we would have to send the patient, they would have to transfer their own blood, and it was a half a day for a patient to get serum tears. Now it's about 30 minutes, right? And they can get it anywhere. Sometimes there's situations where we'll send a phlebotomist to the house, right? And they can actually have that taken care of. Some of these things you can do in your office too, but for me, as I use a service to be able to get this to my patients, so I don't have to have the burden of taking this on myself. So I'm prescribing it, and then my staff is sending the patient to a specific lab to do their blood draw after we get their order in, and then the patient's going to usually be able to get it within 48 hours after we do that draw.
Yeah. So this is really the serum of the blood, right? We're drawing the patient's blood. It's getting sent to a lab that we work with, and they spin it down. They spin it down, centrifuge, take out the red blood cells, take out the platelets in autologous serum. Maybe we leave some of those in. There's different things we can do there, but we're spinning it down. We're taking the serum, and then we dilute that, usually with balanced salt solution, to a certain percentage. And then we have all the proteins, the electrolytes, the growth factors of that serum, putting that in a bottle so patients can deliver that topically to their eye. There's different labs that'll do this. I don't believe the question popped up. I don't believe Quest will do this. They might do the blood draws, but I don't believe they do any of that. But you have to reach out to your area. There's some national providers that'll do this for you too. We're going to try and stay on the science side and not get into the commercial side, but we can answer offline if you're looking for someone to help you do this. And we'll talk about it later at the end of the meeting as well, in the sponsor part of the meeting. But we're using this blood to harness its healing properties as a biologic, as you said, Damon. And so really when I think about artificial tears, I'm really kind of moving away. Like, artificial tears is not a dry eye treatment, in my opinion. I don't like that they're called artificial tears. There's nothing tear-like in them. They're really artificial, but there's nothing tear-like in them. And so they're so common and so used, but I really don't think of them as a treatment for my patients. They might be a patch or something that, the patients can do to feel some instant gratification, but it's not really treating the disease, in my opinion. How do you feel about that?
I think the drops provide some temporary relief for patients, and it can be used in patients with various levels of disease. But if somebody has true keratopathy sicca, and we're thinking that we're actually treating the disease with artificial tears, there's very good evidence to show that that disease is progressing. And the patient may feel some temporary relief, but that doesn't do anything to address the inflammation, the meibomian glands, the neurosensory abnormalities. So that's where, we'll see with one of the cases. Sometimes I have people that come into my clinic that are taking 40 or 50 drops a day of artificial tears, and it actually makes the problem worse. You're diluting the things that we need for our ocular surface to thrive. And then, explain it to a patient when we talk about a biologic. Most people understand that, at least to some degree. And I'll say we can either use tissue-derived products. Sometimes we'll use amniotic membranes or placental tissue, or we'll use blood-derived products. We use blood-derived products. We can concentrate the things that your body needs to heal on the surface of the eye. We do that send you to a lab. They do that blood draw. I just say they take out the clotting factors out of the blood, and then they concentrate all the good stuff into saline, and that becomes your biologic teardrop, not your artificial tear. So it's a completely different conversation when we're talking about serum versus artificial tears, because they really don't share any of the same properties.
Yeah, exactly. So a real treatment for the disease. And so what are in serum drops? We have growth factors, we have epithelial growth factors, we have nerve growth factors. All these things that tell the body to heal are found in our blood. And so we're trying to harness the power of those proteins and growth factors. Vitamins, nutrients, electrolytes, immunoglobulins. So surface immune environment can be transmitted and help keep that healthy. We know how good the tear film is with fighting off pathogens for the most part. And we don't want to, we know that artificial tears don't do that. But it has all the proteins to help avoid apoptosis of the epithelial cells, help them regenerate, help them multiply, and help them migrate a lot too. If we're telling them to grow and move and shake, get going, it gives them the opportunity to regenerate those cells. And that's where the regenerative medicine comes in.
I mean, talking to a patient, this is going to have concentrated growth factors, vitamins, and proteins to help the surface of your eye heal. That's how I explained it to him. Jake, I hope you're not talking about immunoglobulins and fibronectin in the Twin Cities metro area, because I don't, in central Indiana, that doesn't really fly.
No. Yeah, it gets a little deep into the weeds, doesn't it? All right. So why should we reach for this sooner, Damon? Why shouldn't we wait until this patient has end stage, corneal melts and things like that? But why should we reach for this sooner?
Great question, Dr. Lang. And I think it's because we have a much better understanding of what's going on in ocular surface disease today than we did 20 years ago, right? We thought everything was just inflammation and tear supplements, and that's what we're going to do. And then if that doesn't work, well, last resort, especially when it's hard to get, is to do some sort of biologic. But now we know that a lot of these patients, you're treating them and they're not getting better, or they have symptoms like pain and photophobia that you're not going to be able to fix by doing thermal pulsation or doing immunomodulator. That may be part of their disease process, but I think it's our understanding of what's driving ocular surface disease and neurosensory abnormalities being a big part of that more and more. And this whole spectrum of neurotrophic and neuropathic. And when I start to hear key things, or I see certain patterns on the fluorescein staining, or more likely, I just look at this patient's journey when they come into me, like, you need a biologic. And it's something that it's forward in my mind now, because I understand at least a little bit about how all this works. I think we're still learning. There's still a lot of things we don't know all the answers to.
Yeah.
But I know that waiting until you've tried everything before you say, oh, maybe I should try to do something to nourish the surface of the eye besides an artificial tear. I think that it's we just understand the disease more.
Yeah, I think it's right there. I think you said it. It's nourish and heal. And I'm looking at your eye, Mrs. Jones, and you've tried X, you've tried Y. We've done some things. You've done your artificial tears, and your eye is still sick. And we have the opportunity to use these drops to help heal and nourish the surface of the eye, and that's what it's begging for. And so that's kind of how I break it down to patients. And when I look at an eye, like, I have the opportunity to help this eye heal. And that's my goal as a doctor, to make that eye healthier, to feed it, to nourish it, let it grow, let it thrive.
I think that's one part of it, Jake. But I think the other thing is, the eye doesn't have to look like a train wreck to benefit from Serum. You got to listen to your patient. What are they telling you? Hey, this used to work, it doesn't work anymore. Or I can't even go out in the sun because my eyes are so light sensitive after I had my cataract surgery and LASIK enhancement, right? And you look at it and say, what's the problem? Your eye looks pretty good. Am I looking do you have cell? Do you have some sort of neurologic disease? It's like, no, they got a nerve dysfunction, and we need to do something to address that. So I think part of it is some of these eyes, and you have a few train wreck eyes that are in our cases, but some of it is just listening to your patient, and they'll tell you that they need something, they need a different path.
Yeah, they're telling you that the eye is starving for blood. So who should we think about? Who might benefit from earlier disease? So we made some notes here, like people with staining that's not improving, moderate to severe aqueous deficiency, or someone you think has an aqueous component, or even a hyperevaporative state where there's not enough to support that. Nerve things, any neurotrophic risk factors. What are the big neurotrophic risk factors for you that just come to top of mind, Damon?
Somebody that's on multiple preserved medications, glaucoma treatment, multiple surgeries, diabetes, other sort of systemic autoimmune disease. It's usually, if someone is in that neurotrophic risk, similar with our dry eyes, there's usually a culmination of different factors. And I'll specifically list those out for the patient as to what I think are driving their symptoms.
Yeah. I love that you said all those things and not like herpetic eye disease, because, it's the thing that we're all taught in school. Oh, this is what causes nerve damage and neurotrophic keratitis. It's herpes. It's always herpes, right? But I agree with you. Like in my clinic, I see all the other things. It's the scleral buckles. It's the tubes and trabs. It's the BAK from 4 medications for 15 years. So I love that you said that. Anything that causes recurrent epithelial breakdown, corneal erosions, dystrophies, anything that might be causing that epithelial breakdown, autoimmune disease, and then surgical stuff too, post-surgical, other things besides just nerve damage that we're going to talk a little bit about. So let's delve into some cases. We've talked about science and pathophysiology long enough. I know a lot of our attendees are clinicians. So why don't you take us into the clinic of Damon Dierker?
Yeah, what's fun is I chose 3 cases that are all recent. These are all patients I started seeing this year. And some of them had been through a lot as far as their dry eye journey. And then one of them didn't even come in with, dry eye as far as what their problem was. So this was a patient I saw, 58-year-old female who had literally 8 years of been through the ringer, seen several different doctors, been on all sorts of prescription therapies. She's relying on topical steroids and Lumify and frequent lubricant drops. And she just says she's so frustrated. My eyes are always red. People look at me and they wonder what's going on. Did I go out late last night? I'm embarrassed by how I look. I can't wear makeup. And then I'm on these different therapies, and sometimes they help for a little bit, but that never solves the problem. And her eyes are just chronically red, like they're always in a flare despite dry eye therapy. So she came in to me and she was looking very similar to this image that's been generated. I don't typically take photos of a patient just because they have conjunctival hyperemia, but that's really what she had primarily as her presenting problem. Despite being on predacetate and then using Lumify 3 to 4 times a day. So I look at her, her vision was good. Her osmolarity was in the normal range. She was diffusely injected. And then interestingly, she had a follicular conjunctival reaction. I'll always look for that, at least lower. If I'm suspicious, I'm going to evert the lid. I don't evert the lid at every dry eye evaluation. Dr. Lang, do you do that yourself?
Yeah.
I do it when warranted, I think.
Yeah, I think you use your spidey sense. I try and I've tried to be more diligent with that and looking under the lids and trying to be more complete with that. But not, I'm not perfect. My wife tells me
none of
every
us
day.
are perfect, but she's red. She has a follicular reaction. She has minimal corneal staining despite all of these severe complaints. And I looked at her meibomian glands and I was shocked that they were actually really normal when I looked at function. So this really didn't fit a dry eye disease profile. So this patient with redness always being the biggest complaint and minimal other signs other than follicular reaction is this to me is a medicamentosa. I mean, she's on preserved predacetate and preserved Lumify and still looks terrible and has follicular conjunctivitis. So this is a patient that isn't a dry eye patient. You say, well, why are we doing serum for this patient? This isn't an aqueous-deficient. It's because her surface of the eye is just trash. It's been like that for years, being fed these preserved medications. So I identified that we clearly needed to move away from the toxicity of her preserved eye drops. I will often do a in-office irrigation of the fornices and the conjunctiva with saline. And then in this case, she was severe enough that once we flushed everything out, she came back. She really wasn't any better. I actually put her on a week or so of just a Medrol dose pack because she was just so inflamed. And we tried another cyclosporin drop. Just, this is maybe over the first month. I just look at this as like, we just have to hit the brakes here and do something different. So we got rid of the preservatives. We went through a short course of some kind of traditional therapy. As I said, I think you're just going to do really well if we get you on a biologic, because we need the surface of your eye to heal. And she wasn't neurotrophic. It was just the fact that her ocular surface was out of homeostasis for 8 to 10 years, right? So we were trying to reset her surface. That system reset is sometimes what I will tell the patient. So this is a patient that I did as case 1 because she came back and she was in tears. I was in tears because of how much better her eyes looked and how she felt. And she said literally it was a week of being on serum that changed her life. So now she can go back, she can wear makeup, she's confident, her eyes aren't always red. And we got rid of all the stuff that was causing the problem. That's one of the things we have to identify when we talk with the patient is what are you doing to yourself that could be doing this? Or what am I doing as the doctor that could be driving some of this? We put her on serum tiers. In this case, it did 20% QID. And she says it's been life-changing. So I will keep her on that for a couple months. And then maybe we go down to BID to QID and kind of look at her again in 4 to 6 months. So this is one that I was just really pleasantly surprised at how the serum changed her almost overnight, despite all of these other things that we've done. What are your thoughts on that case, Jake?
No, I think that, anytime we can hit it out of the park like this is just so awesome. And, if we think about, I think the follicles and the follicular conjunctivitis was kind of the aha moment that there's something going on. There's something toxic going on here. And I call it a medication vacation, and just get everything out of there. The problem we have, at least in the United States, is all of our steroids, all of our commercially available steroids are preserved. Maybe the ointments, if we can get into that, but they're preserved with BAK. And so if this patient's really sensitive to something that they're putting into their eye or something that's in their environment even, unless you remove it, can you get ahead of it? And, we all know about Lumify now has a preservative-free version, but it was preserved for, the majority of its time on the shelf. So I think, getting that out is huge, but then giving the eye an opportunity to heal and giving that the serum and to see results that quickly, like, wow, that's awesome.
I mean, I definitely think it was a combination of getting the bad stuff out and then getting the good stuff on the eye with the different things that serum.
Well, when it's been beat up for 10 years, it's not going to be able to make the good stuff, right? We know
correct.
That
yeah, it's completely out of whack.
Yeah.
So I think that you eliminate what you can, identify what our chief complaint is, and again, if you think about this, all the clinicians on the webinar tonight is you have these patients that are coming in with chronically red eyes, like why is that, and what can I do to address that? So that's kind of a little bit, I wouldn't say an oddball, but a more unique case that serum to the rescue really was save this patient's quality of life. Case 2, I think, is probably something that you and I, Jake, see more commonly when we're reaching for serum is this patient had seen a few other docs, had seen me once before. We tweaked things a little bit with her regimen, but this is someone that has systemic autoimmune disease. In this case, she has lupus, and she's 61. She said, Dr. Dierker, I'm definitely better than where we started, but I just really wish there was more that we could do. This patient had persistent symptoms despite fairly comprehensive therapy. This is a case where we're using the Fitagrast. I will have patients use loteprednol, PRN for dry eye flares. She also was on a Culturemon for the last 6 months, our topical neuromodulator, and that provides some incremental improvement, but she's still reaching for frequent lubricant drops. She has had lacrimal occlusion. I use hyaluronic acid in my clinic primarily, and she's had a couple of different thermal pulsation treatments. So I've, treated the glands. I've treated the inflammation. I'm trying to help with tear retention, but what am I missing? It's the neurosensory abnormality part, and that's why her cornea looks like this. Her cornea has persistent staining despite being on appropriate therapy. So this patient had a speed score of 17 out of 28, and she's one that probably was a 25 to 28 when she started, so she's better, but there's still room for improvement. And then, realistically, for most of these patients, if we can get them to about an 8 to 10, that's where we want to be shooting for. It's very rare to go from a 28 down to a 0. I've had a couple cases, but you really wonder if that's what's going on there.
I know.
Right. So despite our treatment, she still has abnormal osmolarity. She's got staining. In a case like this, if I see staining, whether it's central or inferior, it's not going away with conventional therapy, I'm definitely going to be testing the corneal sensitivity. I go back and forth today. I think I did it 3 different ways. I had a cotton wisp for one patient, dental floss for another, and then I do have a Brill non-contact. I've kind of gravitated towards the Brill and dental floss. But it just sometimes says, hey, what's available for me? So this patient, intact corneal sensitivity, she does have pretty severe gland truncation, but she has persistent epithelial compromise despite comprehensive therapy. Inflammatory control wasn't enough. Jake, do you see this patient from time to time in your clinics?
Yeah, I think I saw 4 of these patients today.
So these are patients that we can help, but we can do more. And really, it's going to be restoring the surface by going beyond just optimization with anti-inflammatory and lacrimal occlusion and gland therapy and trying to, use appropriate cosmetics and preservative-free tears. Is she really needs a biologic. It's that the surface of her eye is not healing. And I tell patients the biologic, whether we use a amniotic membrane or a blood-derived product, gives things that we cannot do with our conventional therapy and can provide healing properties that can really help us to get over the hump. So this would be a situation where I did a cryopreserved amniotic membrane ×1 for each eye, and there's different ways that you can do that. And then I transitioned her to serum tears, and we're going to get a bump from the cryopreserved. But in this case, she really needed to have more than just that bump. So something that she can use long-term that honestly, I think with the addition of serum, we might be able to get her off a couple of the other therapies that she's on that were, having marginal improvement. So this patient, we did not a full-scale replacement, but more of an add-on to start. So we did a amniotic membrane, and then we added serum tears, 20% BID to QID. And we had an improvement like this several months after. This isn't just a week after a membrane, but several months after, before and after. And this case shows that this, in addition to conventional therapy, can often be very effective. Jake, what's your thought process in these patients that are doing a lot, but we're not quite there? We do something with the biologic, in this case, a combination therapy. Do you start pulling away some of the other things, or kind of what's your strategy for that patient?
Yeah, when I think we've gotten to a place where, like you said, the speed is as good as it's going to get. We've addressed their complaints, we've addressed their symptoms. Their ocular health is in an acceptable place for me, where we've reduced a lot of the staining, their vision's stable. We've addressed all those things. I usually like to give them, I call it like a tincture of time. I'm like, we finally got you here. Let's not change anything yet. And I'll give them 3 to 6 months, depends on the patient and things like that, before I start peeling things back, just to give them a little bit of time to let things be healthy. And then you're right, I would peel back some pharmacologic things, probably, the steroid pulses. We'll start to see those patients coming in saying, over the last 3 months, I haven't used the steroid pulse. I used to be doing that once or twice a month. I do a couple drops here and there. I haven't done that in 3 months. And that's you're getting better. You're getting healthier. Things are moving in the right direction. So if we can start to pull things like the steroid pulses away, if we can move some of the other things away that, are less natural than serum, I think it's a great opportunity to continue to heal that eye. I think your point here is kind of cut on that last case too, cutting back and giving the patients a little more freedom. Instead of using the serum 6 times a day, I want you to go down to 4 times a day and then twice a day. Tapering it almost like you would a steroid in uveitis is a great opportunity too. And serum drops allow you to vary that dosing. They allow you to vary the concentration. And so you get a lot of control over that taper.
And I would say probably even in a referral clinic, 80% of my patients now, I try to keep it simple, stupid, is 20% serum QID to start. Now, there are situations where we need a higher concentration. There are situations where we need more frequent dosing. But if you're just getting started with this, don't try to complicate it. And I would say that 20% QID for most things we're going to see in an optometric practice is a really good place to start. Yeah. And then we can go from there. And then there's patients that you also want to make sure that what you ask them to do is going to be realistic. There's some patients that come in and they have their spreadsheet and their checklist and they'll do everything I ask them to do. There's other, like, if I can get them to do one thing, it's a win. And I think
you're telling them
to understand that.
Yeah, you're telling them 4 times a day, and you're like, that's getting in the eye twice a day if I'm lucky, right? I'm just gonna
4 times a day is maybe going to be BID to QID for a lot of our patients, so we can individualize it. But this is a really nice outcome in a patient that this is maybe our classic sort of dry eye, autoimmune, some aqueous deficient, layering on serum, but it's something that I think that you could certainly, if you're not seeing results from conventional therapy pretty quickly, I think you could pivot to serum earlier in this case. Let's go to my final case, which is the unexpected diagnosis, which I know that if you're looking for this patient in your optometric clinic, you're gonna see this patient. You gotta look for him though. So this is a 72-year-old male who came in and said, my vision is just not quite as good as it used to be. They are a glaucoma patient. They didn't present with a symptom. They presented really for their 4 to 6 month glaucoma follow-up. Eyes are comfortable, really never been a dry eye patient. They are compliant supposedly with their timolol and latanoprost. This was a patient that we tried to do some things in the past to avoid some of the medication burden. We talked about MIGS at the time of cataract surgery. I think there were some coverage issues there. Patient has been recommended SLT in the past, did not want to do that. There's a small segment of my patient population that just doesn't want to do anything that they see as surgery or laser. They're just scared of that. And I don't see that a lot. I think it's how you present it, but this was a patient that's various reasons didn't want to do that. Also known to have steroid response. So I look at a patient, especially glaucoma patient, moderate glaucoma, steroids aren't going to be our friend for that patient. So this patient, blurry vision, their glaucoma is not at a point where it's making their vision and their acuity reduced. We have to be thinking about doing something more for this patient. They also look at this risk factor. This patient has had eye surgery. They're diabetic. They're on multiple preserved eye drops. There's 3 strikes right there. Jake, I know that when you see this patient in your EHR, before you even walk into the room, you're thinking, I need to rule out NK because this patient is at high risk. And exactly. This will be one where our 4th year optometry students, they say, hey, did you remember to put fluorescein in the eye for this patient? Because if you don't, you're gonna miss this unless it's just, rip roaring NK. Yeah. This is the patient has got fluorescein, their vision's reduced, they've got inferior intrapalpebral staining, they're on long-term preserved glaucoma medications. I actually rarely do Goldman. There's rarely anesthetic going in the eye for these patients. I do non-contact with a device called the ocular response analyzer, the Aura, and I get IOP-CC of 12 and 13, which is the way I measure most of my IOPs unless something doesn't add up. But I see this patient and their vision's blurry and I don't have an explanation for it. You put fluorescein in that and say, holy cow, there we go. That's enough to reduce their acuity. And then I will do my corneal sensitivity testing, whether it's with a non-contact Brill or a Cochet-Bonnet or cotton wisp or dental flosses. I can make this diagnosis here literally in under 2 minutes with the patient's history, some fluorescein and some dental floss. What are your thoughts about that?
I think that's it. That is it. Yep. We got to identify the risk factors, acknowledge that the patient's complained about vision, not pain, and say, oh yeah, that doesn't add up, and then poke them in the eye.
So now this is where it gets interesting. We've made that diagnosis. We looked at those risk factors. This is stage 1 NK where they have epitheliopathy, SPK, PEK without having a larger defect or any sort of ulcer. But this is the one that's going to be most common if we're looking for it. And this is a patient that we need to identify, what's driving that. We can't control that 15 years of diabetes or past a history of ocular surgery, but we can look at the toxicity that the drops are causing. So why serum here is, let's transition to preservative-free glaucoma drops. Again, patient SLT is still not interested despite all of this. And this is one where I chose this case because this is one where serum early actually makes a lot of sense. And you can probably get by doing serum for just a couple of months and get this patient back on track. If we remove the offending agent, we get a more reasonable strategy for IOP control, and then we do something to nourish that ocular surface that's been damaged from multiple risk factors. So I did 20%. I said this patient probably is going to need to be on it for a couple months. And this would be one, it's like, well, maybe put a steroid or maybe do a membrane. There's reasons not to do that in this case. And the patient doesn't really want anything in or around their eye. They're okay with eye drops. So this is one where I say, let's just do some serum for this patient for a couple months and see what happens. And it doesn't even take a couple months. This is a pre and post. This is probably 6 weeks. We got the preserved drops out of there. We switched them to preservative-free the tanapross. Sometimes a case like that, you can go from 2 agents down to 1 and have just as good of IOP control. And then we see that their cornea is crystal clear after we've done our treatments, and their acuity is better. So these patients coming in that have multiple risk factors is dig a little deeper, ask some questions. Don't be satisfied with a soft 20/20 acuity or someone is coming in, their vision's not blurry. Find an explanation. A lot of times it is going to be your ocular surface, and then do something to turn the page for this patient.
That's it. Love it.
Jake, you've got 1 or 2 cases here to kind of wrap up this portion. I know there's a lot of questions. We'll try to get some. We'll definitely take some email questions afterwards too. But this is exciting stuff, and these are cases that I think we all see that could benefit from a biologic.
Yep. And I think we've all seen patients, like if anyone says they didn't see a patient with autoimmune conditions, like you're just lying to yourself. Like anytime you see Synthroid in their med module, they have an autoimmune condition. So these patients are in all of our clinics. I'm going to run through some quick ones, cases, but I want you to think about like, what could I do to be better? What could I do to be more proactive and less reactive? So when the drops become the problem here, this is a post-cataract patient that calls me at day 8 saying my vision's getting worse. And, anytime I hear that, I'm like, oh, geez, I hope this isn't endophthalmitis, right? So we're about that 1 week period and they're like, my vision's going down, things are bad. I'm like, oh, you got to get in here right away. And, I don't know if I want to say thankfully, they had something I can fix and not, something that's going to be a fight against an infection. But we're trying to do this patient a service by taking out their cataract, and their cornea comes in after this for a week for taking an NSAID, a steroid, and an antibiotic that were all preserved, unfortunately. We know that cornea probably was sick beforehand, and we just didn't catch it, and then we put the straw that broke the camel's back right on top of it, right? So this is a great opportunity to remove those toxins, remove those bad things, and nourish or help heal the cornea. So again, similar to Damon's story, like a week of using steroid and we're ahead of things and the cornea is healing, getting things back on point. But, when I see patients like that, I wish I could have done better. I wish I could have prevented them in the first place. And sometimes we get too complacent saying like, okay, take your generic medications, And we know, coverage is a big issue and access to drugs are a big issue. And so we have to recognize that we'll have challenges. And then the old carpenter's theme here, measure twice, cut once. Maybe we should use this in eye care more. How do we optimize this eye for biometry? So here's a cornea. Hopefully you can all see it. And we're seeing some irregularity in regards to the fluorescein pattern, right? This is the poor man's topographer, where we're seeing some areas of negative staining and some areas of pooling. And that's telling me, hey, this cornea is lumpy, right? This patient has significant anterior basement membrane dystrophy. So they've got an irregular cornea and they have a significant cataract. So what do we do if, see cataract, hit cataract? Is it our only tool, again, with a maybe carpentry mentality? If we have only one tool, a hammer, every problem is a nail. But we need to recognize that the cornea plays a big role in our vision as well. And if the cataract is ready, we have to ask ourselves, is the cornea ready? And so we should be checking both those things. And so if we're seeing that anterior basement membrane dystrophy, we need to treat that first so that we can get better K measurements and do a better job with this patient's refractive outcome in their cataract surgery. So how do we fix ABMD? How do you guys fix ABMD in your clinics in patients that are looking for an optimized, perfect cataract surgery, Damon?
We're doing SKs, and in Indiana, we as optometrists do that. My rule is if a epithelium is intact and we're doing this for refractive reasons, I'm going to let our cornea fellowship trained ophthalmologists be the ones to do their SKs and ocular surface optimization. If someone's coming in because their cornea is irregular and they're uncomfortable and they're getting erosions, it's like I'm more than happy to take that diseased cornea and wipe it clean with a Wexel or a spatula. But for a refractive case, it typically is going to be our surgical team doing SKs, although some of our optometrists do that as well. That's just kind of my personal algorithm, given the resources we have in my clinic.
Yeah, so I think this is a great opportunity for Serum to help this patient get to cataract surgery sooner. And so if we, doing an SK, we should see that patient. If you're referring them to a corneal surgeon for that, I think using Serum as soon as we're diagnosing this irregular cornea to help nourish, help feed, help heal that surface and get them ready for the cornea surgery that they're going to have is a great idea. And so starting that, I usually do 30%. I would probably do 6 times a day with this patient just to be aggressive. It's the American way. More is better, right? And so just more is better. And so get them started. Let them do the PTK. We're going to see quicker epithelialization because we're nourishing and feeding all that epithelium, helping those nerves tell the epithelium where to go. We're going to get a smoother cornea quicker, get better Ks, better outcomes for this patient long term. And the big thing I wanted to bring on with this is what I would love to see is the optometrist recognizing this ABMD 5 years ago and telling the patient, like, your cataracts are coming. You've also got this lumpy cornea. We should start working on this lumpy cornea now so I can rehabilitate that cornea over the next 5 years. And then when you're ready for surgery, maybe you don't even need a PTK. Maybe you don't need an SK. Maybe you've got a much healthier, stable cornea in the first place. And we have the opportunity to do that. But a lot of times we get busy doing other things and ignore some of the things that we can treat and we can be proactive with to help our patients prepare for cataract surgery over years, not weeks. Let's talk about just how do you prescribe this? I'll go over my kind of things and then I'll let you say what you do different. And then we'll wrap this up and get into the questions because we're kind of getting into that anyhow. So I use Vital Tears as an organization, as a lab that I can partner with. They do a great job with my patients in handling the costs and expenses and coverage. So I just write the orders and put it into the portal. Actually, my technicians and clinical assistants do that. I usually prescribe 30% concentration, and depending on the disease state, I'm doing at least QID to start, sometimes more 6 times a day if there's a really sick cornea, persistent epithelial defect, things like that, then we're talking about 6-8 times a day. I will use it in the bowl of a scleral lens as well as a therapeutic delivery device. What else am I missing? The patient will either have a phlebotomist come to their house, or we're lucky to have a clinic, just a primary care clinic next door to us that we've kind of partnered with, and they will get the blood draw done for them, and they will ship it to Vital Tears. It gets spun down and diluted to my recommendations and sent back to the patient very quickly. So it's been very efficient for me. Damon, is there anything different you're doing or saying to the patient here?
Like I said, I've evolved where I used to use 20, 30, 40, 50. Lately, as I've been ramping things up, I've just been doing 20 QAD and having good results with that. So that's where I start with the majority of my patients.
Great. Excellent. And then we can taper that over time. Again, we think of dry eye as a chronic condition, so probably going to be treating these patients for a long time. I think more is more with the duration of treatment. And then safety management, sterility, these should be kept frozen unless the bottle they're using, that one should be refrigerated. Avoid contamination because this isn't preserved And there's instructions for the patient on duration, when they should be thrown away, all those sort of things. I did have a patient I saw today who's on serum drops for a regular limbal stem cell deficiency from glaucoma surgery, and she keeps it in her Stanley cup. So she's got her Stanley cup and she keeps her serum drops in there on ice to keep them cold throughout the day. So she's not drinking coffee or juice or tea out of her Stanley cup. She's got ice cubes and some blood serum in there. But it's a really like handy, like, simple thing. And it has been very effective for her as opposed to like the lunch cooler and all that stuff.
Yeah, the Yeti cups work too. So anything that's a mini cooler for the patient to bring around, and that's how we're going to keep this from being, keeping this safe as we do this, as you alluded to.
Yeah.
So yeah, some of the stuff here to kind of wrap up is hitting some of the things we've already talked about, and core message, identify earlier, prescribe confidently, and then find a partner to be able to do this. And I started off the presentation is, why am I doing this more and having more success? Because we have a partner like Vital Tears that makes that more accessible. And that's been a big thing for my patients in my practice. So it's been great. And I'm seeing this in a variety of patient types.
Great. Well, Jennifer, should we dive into some questions and wrap things up?
Absolutely fantastic. I wish we had another hour. I was seeing your slides. I was like, oh, I wish we had another full hour because there's so much to go over and so much information. But thank you both.
Opportunity.
Well, if we need a part 2, so everyone put that in your comments. But you did answer a lot of the questions. I was trying to keep track. A lot of the questions you answered kind of right at the end. And I know we don't have too much time. And you may have answered this, but this goes back to your first case. What ICD-10 code did you use? And does insurance ever cover serum?
Yeah.
Great question. The first question is easiest to take on is I use the toxic conjunctivitis. And then serum, I have heard, and I'm not sure that I have anybody personally, but I think there are ways for a patient that's an advocate for their own healthcare can try to get that covered, but it's going to be positioned in my clinic as mostly an out-of-pocket cost. How do you do that, Dr. Lang?
Yeah, it's out-of-pocket cost. There's a lot of out-of-pocket costs these days, and so more and more we're seeing like things aren't covered. So I think it actually is more of an opportunity for utilization of this because, it's not covered. And so the other part of that is diagnosis code doesn't matter, because the patient's going to be paying for this out of pocket. So you don't have to worry about putting this code first and that code second. Just do it and code whatever you want.
Yeah.
What steroid do you typically use for pulsing, and at what dose?
So we have on-label lodiprednol, Isuvis for a label of dry eye flares, QID up to 2 weeks. I tell my patients up to QID, up to 2 weeks. Most of my patients would just use it a few times a day for a couple days to get through a flare. That's what it's there for. I think you can use other lodiprednol products as well, but that's the one that is going to be your on-label. And then if I'm doing something that is going to be for a short term, I won't have a patient just have pred acetate as needed. I want something like lodiprednol that's a little bit safer.
Perfect. Well, with that, I think we are out of time, but I want to thank both of you for all of your time. And if we didn't get to your question, I see questions popping up. Stay tuned because you'll have more time to ask those questions. And thank you to Vital Tears for sponsoring tonight's event. Stay tuned for more information on serum tears if those questions weren't answered, and if you're ready to use them in your practice, how you can access them. Here is that QR code. And then if you miss it, don't worry, you can still access. And we'll hear more about serum tears in just a moment.
How are you guys doing?
We are good. We are ready to hear more. So I'm going to go off camera. The reminder still applies here. Make sure to ask those questions in the Q&A if we didn't get to them in the other room. And I'll let you take it away, and I'll be here at the end for Q&A.
All right, thank you. So thank you guys. That was a great presentation by Dr. Dierker and Dr. Lang. Thank you guys. So I'm going to kind of dive into Vital Tears and what makes us unique. So who are we? So we were formed in 2015. It was kind of in a response to, corneal specialists, ophthalmologists. They were doing serum tears themselves in the practice, and it could be a burden on themselves and their staff. So we wanted to make it more effective and easy, stress-free for them. So Vital Tears was formed in order to offer a much easier, smoother option for the patients to get serum tears. So what is the process? So first off, as a physician, you do need to register on our Vital Tears provider portal. The link is here, portal.vitaltears.org, or you can even just Google Vital Tears and you'll be directed there. So orders are placed on the portal. You do need to put in the patient information, of course, but specifically you need to have the concentration. I know the doctors talked about what they usually do, but normally it's probably about 20 to 40% is the typical concentrations, and there is higher concentrations available as well. A dosing schedule, and it sounded like they're around about 6 times a day, and then the number of refills. So with our refills, we do have an automatic set for 3, but you can change that to 0. You can change it to unlimited so that we will take care of setting up those blood draws, which we'll go into that in just a moment. So the process is once you place that order on our portal, our patient services team will contact the patient within 24 hours to set up their blood draw. So we have contracted labs throughout the country. So we will pull up based on their location, but they always do have the option of mobile phlebotomy. We do offer that at a higher, just for $20 more for the patient. So it can be done in the convenience of their home. Where we might not have a lab, or a patient just rather have the privacy of their home as well. We do collect the payment, so you don't have to worry about that. We coordinate, like I said, that blood draw, and then we do ship to the patient directly as well. So how it works is that blood is shipped to our laboratory, and then our highly trained technicians produce this tears in a aseptic environment under a laminar flow hood. So we are providing consistent serum drops for the patients. So after they are processed, they are shipped back to the patient. So our patient services team will reach out to them to schedule the shipment. It does arrive on ice, so they also need to sign for it. So we are setting that up with the patient. And then when it's time for that refill, we will reach out to the patient again to set up their next blood draw. So here are your ordering options. Available concentrations for the standard is 10, 15, 20, 30, or 40. The higher concentrations, 50, 75, and 100% for maybe those patients that are more severe. And then the ordering options, we have a full order, which is approximately a 5 to 6 month supply, a half order, 2 to 3 month supply, and then a high concentration order. The reason we give kind of a range, because it all depends on the quality of the patient's blood draw, and our patient services team will educate the patient, make sure they're fully hydrated, really to avoid caffeine and alcohol within 24 hours. So here's our pricing. So our half order is $425. We do offer an introductory order for $399 for new patients. If a patient's going to be on this long term, it makes more sense to do a full order at $699 because one, it will be less blood draws, it's more cost effective, but we also offer a monthly payment option of $130 per month. We do not take insurance at this time, but we do help with them if they want to submit for reimbursement. We will certainly help them with that. And then the high concentration order is available at $699, or they can have 2 installments of $350. So what it includes is that blood draw. It's additional for the $20 mobile phlebotomy. It does cover the processing and formulation, and then all that overnight shipping from the lab to our facility and then back to the patient. So once again, to get started, you do need to register our portal as a provider. And then we, as myself, and then we also have another rep as well, Scott Sjögren, we will be in contact with the office, make sure you guys have everything you need, marketing materials to promote this. So I will open it up for questions now.
Perfect. We have quite a few, so I have a list.
Boy.
So, all right, get ready. People have a lot of great feedback. First of all, are there any overseas options at this time?
At this time, I do not believe there is with vital tears, but I'm sure there are other serum tear options. We can definitely get back if that is incorrect.
Are there any contraindications for serum tears?
There's actually no contraindications. However, if there is a patient with a low blood cell count or they're undergoing chemo, I would best check with their oncologist to check if they are okay to do it.
Let's see. How do you counsel patients on obtaining, using, and storing tears?
Yeah, so as I mentioned, a 6-month supply reduces the number of blood draws, so they would only need twice a year versus the half might need 3 to 4 a year. It also provides a cost savings for the patient. Patient must be counseled to store their unopened vials in the freezer. So it does come on ice. The vial they're using for that week can be stored in the refrigerator. Now, I'm in Arizona, so it's pretty hot. People are in their cars going to and from work. There are portable coolers you can use, insulated mugs. I know a Yeti mug is great to store in there with ice to keep it cool for those hot summer months.
How do you determine the concentration and dosing, and does this vary based on the disease state for the patient?
So just important to note, there is no consensus paper or study that states what is the best concentration, but it is reasonable to start at 20 to 40% because at this concentration, dilution will retain good amounts of the proteins, the vitamins, the growth factors that are found in the serum and can be used for rehabilitation for the ocular surface. And as mentioned in the presentation, it can be used 4 to 6 times a day. Maybe in those more severe patients, you may go to that higher 50 to 75%, and maybe that 6 to 8 times a day. But the cost at the 20 to 40% profile is less than higher concentrations, which can make it a good starting point for patients.
This next one is a 2-part. So it was a 2-part question. So I'll give you part 1. How long should a patient expect to be using serum tears before they see any improvement? That's part 1.
Okay, so typically it is about 2 to 4 weeks. Obviously, every patient is different based on their severity of the ocular surface disease. So, it can vary.
And how long do patients typically stay on the tears? That's part 2.
So another good question. So it all depends what they're on it for. So there are some patients, I know they mentioned post-op patients. So they may be on a shorter stints during that 90-day post-op period. But then the patients that are, have autoimmune disease or, chronic dry eye, that's just nothing else is working. They may be more on it more long-term.
And I know you mentioned this, but this question keeps popping up again and again. Is there any insurance coverage? Can you just go over that one more time? Because I think that's probably the biggest question I see.
Yes, for sure. So Vital Tears, we are actively seeking reimbursement for insurance. We are covered under Aetna, but it depends on the region. It also depends on the patient's plan, but it's not something that we are submitting for reimbursement. Patients will need to submit that themselves. What that involves is a medical necessity letter from the doctor, which we can provide that. And you would just put it on your letterhead. It's a very simple one. It's not crazy like some of the other medications out there. And then they would need an order report, which is their prescription for the serum tears, and also a receipt from the serum tears, which our patient services team can help provide.
Perfect. How much blood is drawn for a full order?
It all depends. Honestly, I mean, typically in a full order, there are going to be approximately 26 bottles. In a half order, there's approximately 13. We try to get as much as we can, but it will never be over a 6-month supply because with biologics, we can't guarantee the efficacy after 6 months.
There's just a comment here from an attendee that Marimo Labs, I may have pronounced that wrong, in Cambridge makes a capsule to keep meds cool in an upcycled Yeti without refrigeration. So just a comment there.
Yeah, good to know.
So just in case you don't want to use your real Yeti, can a patient use their HSA or flex spending?
Yes, very good question. I'm surprised I forgot to mention that. They can use their HSA, FSA. We also do accept care credit.
Perfect. What is the vehicle when it is less than 100%?
So it is BSS, so it is preservative free for the patients.
Perfect. And let's see. If a patient is immunocompromised, are they still getting proteins, vitamins, etc. in the serum tiers to get the most benefit?
So good question. I probably cannot answer that, so I would probably defer that to our clinical specialist on our team.
Let me just check and see if there's any. That was rapid fire. I think that's the most questions I've done so quickly. We had a lot of questions, but great questions. I'm looking just to check if there's any that we missed. I think I got them all. Any last minute questions that we didn't answer in that rapid fire? Well, while I'm waiting for those to come in, if there's any that come in, I want to thank you and thank Vital Tears for being here. Wonderful information. I think we all feel a little more comfortable about prescribing this for our patients, talking to our patients about it. It's not as scary maybe as it once was, and not, we're kind of understanding how to do it and how to talk to our patients about it and how to get them the treatment they need. So with that, I want to thank you. I want to thank everyone for being here. It doesn't look like there's any other questions that have come in. I think we covered it all. So.
Perfect. Well, thank you everyone for having us.
And thank you everyone. Have a great night, and we'll see you at the next review. Have a great night.